Okay, thank you for the invitation. Actually, the title of my talk is In Vivo Evaluation of EGFR Mutational Status. Since I am a chest physician, I'm interested in lung cancer, and the outline of my talk will be to show you where we were in lung cancer and how we moved on to the present time, where we are really, I think, moving into personalized, or I like the term precision medicine better, and how imaging can help to aid clinical decision making in precision medicine when it comes down to selection of patients for treatment with EGFR tyrosine kinase inhibitors. Okay, to appreciate where we come from, I think this is an important slide. In the late 1990s and the early 2000s, the prospects for patients with advanced non-small cell lung cancer, so that's metastatic non-small cell lung cancer, were actually very grim. We had a sort of one-size-fits-all approach when it comes down to chemotherapy, which typically resulted in objective response rates somewhere between 1/4 or 1/3 of the patients who had evidence of shrinkage of the tumor, and median survival rates were approximately 9 to 11 months. And it actually took a very long time before we could hit the 1-year barrier. And the 1-year survival rate were approximately 40%. So, you know, nowadays these waterfall plots are very popular to show on the graph, but actually the waterfall plot for patients with advanced non-small cell lung cancer in the early 2000s was somewhat like this. A natural phenomenon where people would die off very soon after the start of therapy. Now, researchers began to recognize, or had been recognized, quite frankly, for a long time, that there were certain important mutations present in certain lung cancers that would actually define prognosis and reaction to certain drugs. It were really the appreciation of the EGFR HER2 mutations, HER2 of course in breast cancer, but the EGFR mutations that were discovered in lung cancer that set the stage for the development of many other so-called driver mutations, so mutations that characterize the cancer in lung cancer. One has to remember, or what I like about the way it was found out that EGFR actually was a driver mutation in lung cancer, came absolutely by serendipity. There was this physician in Dana-Farber who treated a patient with an EGFR tyrosine kinase inhibitor. I will come to that. And the patient, one of these patients had a very, very massive response. And next to him was a geneticist. And he said, well, you should look for mutations in tyrosine kinase domains, because this is what we see in BCR-ABL mutated patients. And then they sequenced the whole tumor and found out that this patient had an EGFR tyrosine kinase EGFR mutation. And that's what set the stage for the development of these drugs and for the way research was done in lung cancer. And nowadays, we have quite a few of these so-called druggable mutations. You can see here, adenocarcinoma in 2013 is not one disease. It's actually a disease which segments into a lot of diseases which are all characterized by a single mutation. Of course, there are many more mutations, but at least these are the so-called driver mutations. And what's more important, for all of these mutations, we have drugs that actually work. So it becomes really important to find out what kind of a mutation your patient with an adenocarcinoma of the lung has. And the same more or less holds true for non-small cell lung cancer, although they are a bit behind adenocarcinoma of the lung, squamous cell cancer. Nowadays we know of at least 6 defining mutations that are auctionable, that's to say where we have currently drugs for. Of course, there's a big chunk of unknowns, and we will work on that. But all in all, approximately 45% of all patients but metastatic lung cancer do have a defining mutation. These mutations are not very frequent. This is the most prevalent mutation, the EGFR mutation, which was discovered already in 2004, as I've shown you. And a large database in the Netherlands was accumulated over the last 4 years, where over 5,000 patients were sequenced for EGFR mutation. The prevalence seems to be approximately 10%. Now, if you go down the pie, of course, here we have the ALK fusions, which is the second most prevalent mutation, approximately 4%, and then you come in the low 1 or 2% range. So although there are very much a number of these mutations, the actual frequency of these mutations may be very low. Now, if you have an EGFR mutation, what is the net result in terms of biology? You know that EGFR is a receptor with an extracellular domain and an intracellular tyrosine kinase site. We have to, in order to get downstream signaling, these receptors have to dimerize, and if you have a mutation, there is preferential heterodimerization with other member of the EGFR family, which is called HER3, which really leads to increased signaling through the AKT instead anti-apoptotic pathways. In other words, cells don't die. And this leads to the phenomenon which is termed oncogene addiction. So the cancer cell, for its existence, is dependent on the action of the activated pathway. And that has been shown here. So the idea is now, if you can disrupt this pathway, cancer cell will go into apoptosis or will differentiate. In reality, it's probably much more difficult, but this is the general idea. If you knock out this gene A, where the tumor cell is addicted to, cancer cells will go in apoptosis. So it becomes relevant to know whether A is present in a cancer cell. The ideal, I think, for the current approach of cancer treatment would be something like this. You have a patient, you take out tumor cells. For lung cancer, this is something that is already very difficult to get enough tumor cells to extract RNA or DNA, for that matter, to some kind of array experiment. You detect gene activity or gene mutations and expression profiles, and you establish a diagnosis. And the diagnosis might be something like adenocarcinoma, stage 4 of the lung with an EGFR mutation. And then, in the ideal world, you also would have treatment available. So I think that when it comes down to precision medicine, lung cancer treatment in 2013 becomes more or less like this. Why would we test for these alterations? Well, the obvious answer is we have drugs that work in the face of a specific alteration. In other words, these smart drugs. And one of these smart drugs, when it comes to EGFR mutations, are the EGFR tyrosine kinase inhibitors. There are the two most prevalent EGFR mutations are a deletion of exon 19 and a point mutation in exon 21. These will render the protein accessible for inhibitors, for the EGFR TKIs, as been shown here. So the exon 19 deletions and the L858R point mutations together make up approximately 90% of all EGFR mutations. And when the drug binds in the tyrosine kinase site, phosphorylation, downstream phosphorylation is prevented, and the EGFR signaling pathway is disrupted, and cells will go in apoptosis. Is that clinically relevant? Yes, that is very relevant, as been shown here. We have numerous clinical trials, and I will show you the outcome later on, where we took these patients with EGFR mutations and randomized them between treatment with an EGFR TKI or cytotoxic chemotherapy. Remember, the same chemotherapy that produced this 25 to 30% response rate and median survivals well below a year. Now, and these are the survival curves. This is a Japanese study where they randomized approximately 200 patients, one to a drug called Gefitinib, half the patients, and then your progression-free survival curve is like this, or classical cytotoxic chemotherapy. And you can see that the hazard ratio for progression is 0.35. So you have a 66% less chance of progression when treated with an EGFR TKI, provided you have a EGFR mutation as compared to treatment with chemotherapy. We have now at least 7 trials available, large randomized phase 3 trials available, where this phenomenon was repeatedly found. You can see here that for phase 3 studies, these are actually very small studies. The beauty of these driver mutations taken into clinical trials is that you have less patients needed to establish a treatment effect. You can see here the median progression-free survival times in the TKI-treated patients. And you may appreciate that these figures actually are the median overall survival times that we were used to see in the early 2000s. P-values are always with a lot of zeros, as are the hazard ratios below 0.5. So these drugs work. They have entered guidelines all around the world, stating that in a patient with an EGFR mutation that has advanced non-small cell lung cancer, an EGFR TKI is the treatment of choice. Needless to say that these drugs have much less toxicity as classical chemotherapy, which was also proven in the randomized phase 3 trials, in that patients treated with an EGFR TKI had a much better quality of life as compared to the patients treated with chemotherapy. So also from the point of view of quality of life, treatment with EGFR TKIs in the face of an EGFR mutation is to be preferred. But there are some hurdles for mutation testing. I think one of the biggest hurdles actually is availability of tumor tissue. So we now start out with doing multiplex testing. We need bigger chunks of tissue, and that will only work in approximately half of the patients. So getting an adequate tumor sample is not evident in patients with non-small cell lung cancer. Of course, there is always the issue of money and reimbursement of these techniques. And also, what I think is important in a psychological sense is that these techniques are time-consuming. Although if you have a large number of patients to be tested, we have a turnaround time at the present in the Free University of a day, 3 or 4 days. Now, I'm glad the previous speaker has set the stage for imaging, molecular imaging. And our thought was that, well, suppose we are going to label EGFR TKIs, can we identify patients with an EGFR mutation? We thought this could be useful for personalized treatment planning in oncology. And the ultimate question, of course, is, does uptake of this anti-cancer drug in tumors predict treatment outcome? So we have a very simple question. We used carbon-labeled Erlotinib in a microdosing concept, so a fraction of the therapeutic dose is injected into a patient. Question 1 is, does the drug reach a target? Does the drug bind in the tumor? And question 2, if the drug binds in the tumor and you treat those patients with an EGFR TKI, does the tumor shrink? And alternatively, patients that show no uptake, if you treat them with the drug, does the drug indeed have no treatment effect at all? So this was kind of a leap of faith, I have to tell you, that this could work. There was no preclinical work whatsoever before it. We simply thought, well, the affinity of erlotinib for the mutated receptor is much, much higher as for the wild-type receptor, so this may work in patients. I'm a clinician, so I find it difficult to treat or image rats, so I rather image patients. So and here's what we did. We took patients with advanced non-small cell lung cancer, where we had histological proof of adenocarcinoma of the lung that expressed EGFR. 5 of these patients had an EGFR activating mutation, so an exon 19 deletion in this case, and 5 who had EGFR wild type. And now we are simply going to compare these patients. I will show you the scanning protocol in a minute. We did a perfusion PET-CT scan. That is to assure that there is adequate perfusion in the tumor. If there is no perfusion, the drug cannot reach the tumor. That's evident. Right after that, we performed a erlotinib PET-CT scan, and we performed pharmacokinetic analysis. So this is the scanning protocol, quite complicated. We had an FDG PET scan available. We made a CT scan right at start, water scan, erlotinib scan. And for research interest, the whole thing was repeated after 4 hours. So this was 4 PET scans at one day and 2 CT scans at one day. Now, if we go to the FDG PET scan, here you can see a patient with a tumor in the left hilar region here, who was found to have a wild-type EGFR. And here is a patient with a tumor in the right upper lobe with a mediastinal lymph node metastasis. And this tumor was found to have an activating EGFR exon 19 deletion. Now, the question is, if we scan these patients, is there a difference? Well, there was a clear-cut difference. If we go to the patient with the exon 19 deletion, green is drug uptake, and you can appreciate that there was a lot of drug that accumulated in the tumor in the right upper lobe. Whereas in this patient, you really have to guess where the tumor is. But you may remember from the FDG PET scan that it is actually here. So where there is no green at all. Better appreciated on these pictures, I think. So there was a significant difference in uptake of erlotinib, so the EGFR TKI, in patients with an exon 19 deletion, which was significantly higher as in patients with wild-type tumors, as expressed by the volume of distribution. Well, you might argue, yes, that's all fine, but there was a big difference in tumor blood flow. Well, we could say that was not the case. Or that there was a difference in EGFR expression, so expression of the protein, which can be seen in EGFR wild-type tumors, and equally well in EGFR mutated tumors. So the difference we saw in drug uptake was not due to a difference in tumor blood flow, nor in EGFR expression. So we really believe that this picture is binding of erlotinib to the mutated receptor. So in this way, we can non-invasively identify patients with an EGFR mutation. If we cannot have a tumor biopsy, and we have clinical suspicion that there is a EGFR mutated tumor, this technique can be used. How can these techniques also be used applied in the clinic? I think at this moment, as we use it, there are 2 applications: treatment of patients with rare EGFR mutations or treatment at relapse. Remember, I told you that the 2 most prevalent activating mutations make up for 90% of all activating mutations in EGFR, and at least 10%, and there is a myriad of mutations in these patients. Over 150 of those mutations have already been described in the literature. And usually what we do when we have a patient with a rare mutation, we go to a large database, somatic mutations, EGFR info, where all information is gathered from patients that have rare mutations. For instance, here you can see mutations that are described in exon 18. And you can see, for instance, here a patient with this mutation. Some of the patients had a favorable response to therapy. Some of the patients had progressive disease. And other patients, the physician really didn't know. So if we have a patient like this, it would be helpful to perform an Erlotinib scan. And I will show you now some examples of that. Few percent of the patients have exon 20 insertions. These insertions generally are believed to be associated with resistance to EGFR TKIs. You can see here a patient with a tumor in the right upper lobe and the left hilar region. And you can simply ask, if we perform an Erlotinib PET scan, does it bind to the tumor? And you can appreciate there is no binding of Erlotinib in the tumor deposits. This patient was nevertheless treated with EGFR TKIs, Erlotinib, and a clear progression of disease after 6 weeks of treatment. Another patient with a very, very similar mutation, also an exon 20 insertion, is shown here. You can see here the tumor in the right upper lobe, and there is clear uptake of the drug, and this patient had a response that lasted over 1 year upon treatment of EGFR TKIs, Erlotinib in this case. We find polymorphisms, where we really do not know what the relevance is. Here is a patient with a tumor in the left lower lobe, and you can appreciate there is no uptake whatsoever, and this patient died within 2 weeks of treatment with Erlotinib. We also can use this technique if you do not understand why a patient with a mutation does not respond to treatment. So this is a young female patient who had a exon 21 L858R mutation, so a classical activating mutation, and she had only very little response to treatment after 4 weeks with gefitinib in this case. And if we made a Erlotinib scan, you can appreciate why this is the case. Because there is uptake of Erlotinib in a small part of the tumor, while the major part of the tumor, which is here in the right upper lobe, readily be seen here and here, there is no uptake at all. So this patient had a very heterogeneous tumor, where some parts of the tumor had the exon 21 mutation, and other parts of the tumor did not have the mutation, and consequently, upon treatment, the tumor parts that did not contain the mutation grew with a lot of complaints, as you can imagine, when it extends through the thoracic wall. Another interesting thing is, I think, KRAS mutations. It is generally believed that KRAS mutations, patients with KRAS mutations do not respond to treatment with EGFR TKIs. And here we have a patient where we could show that it was otherwise. This patient had a bronchoalveolar cell carcinoma with some uptake of the drug in the tumor of the right upper lobe, and she responded well to treatment with an EGFR TKI. So I think this is one application that we could start off if we had all the money available that we would like to have right now. I think another interesting application might be treatment upon relapse. So this was the patient I've shown you in the first picture in 2009 with an exon 19 deletion and a tumor in the right upper lobe and mediastinal lymph node metastases. This patient was treated with an EGFR TKI, had a response for over 1 year, had local progression. We treated her with chemotherapy and radiotherapy. Again, she had a response over a year. And in 2011, she had a second progression. Now, we took a biopsy. Still, the exon 19 deletion was present, but at this time, there was also the resistance mutations and the T790M mutation. The T790M mutation is a secondary mutation, also in the EGFR tyrosine kinase site, but actually prevents binding of the drug to the receptor. And that's why these tumors become resistant to treatment with EGFR TKIs. Now here you can appreciate that in contrast to the tumor in 2009, there's much more heterogeneity in uptake of the tracer, So probably this is a tumor that consists of two parts. One part that can still be treated, that has only the exon 19 deletion, and another part that also has the T790M resistance mutation. And we treated this patient with Erlotinib, and she had another remission that lasted for over 6 months. So what are the future prospects of this technique? I think whole body imaging, I think, is a application that should be studied, where we can visualize intra-patient heterogeneity. We have, I think, enough examples to defend individual treatment planning, and we're going to develop a novel tracer against the EGFR tyrosine kinase site, which is a novel drug, afatinib, and I hope we can start somewhere beginning of next year to image patients with a fluoride afatinib tracer. So I think this way of molecular imaging has the potential to identify non-invasively druggable targets, which I think is of relevance for patients in the metastatic setting, quantify all kinds of pharmacodynamic processes in vivo, but we need ultimately clinical trials to validate these concepts. So I would like to thank all patients and their families here. The amount of names that is associated with this research does not fit into one slide, so I will only mention the departments, radiology, in particular nuclear medicine, pathology, surgery, and our own department. Having said that, I would like to thank you for your attention.
Thank you, Egbert. Are there any questions? Bob.
It's a beautiful study. And I was wondering, I had two questions. You have that curve as that you showed us, but that was progression-free survival, not overall survival. And it doesn't make it less convincing to me. But as a clinician, you wonder how you deal with that. It's the fact that it is not as yet overall survival. And the second question is that you have a drug here that goes to the tumor and sticks to the tumor.
Right.
You can bind radioactivity to it, but you can bind also radiotherapy to it. And Erlotinib is a radiosensitizer also, besides a kinase inhibitor. So have you thought of linking radiotherapy instead of radiodiagnostics to Erlotinib to have the drug effect kinase and the radiotherapy and the sensitizing together in the tumor?
Okay, so I will start off with the last question first and then go to the first. It does not only go to the tumor. So a lot of it actually sits in the liver. So if you couple this to radiotherapy, you will radiate the liver maybe as well. But I think to it, if it is really so specific, you can link all kinds of emitters to it and radiate the tumor from within. That would be, I think, the ideal thing to do.
Yes, I agree with you. So perhaps you should give it the radiotherapy, external radiotherapy, instead of linking it at the same time.
Okay. There are some problems with a combination of EGFR TKIs and radiotherapy in the lung, because it also binds to some extent to a particular cell in the lung, which is called the Clara cell. And if these are damaged, you get extensive pneumonitis and pulmonary toxicity. So these are their own problems of combining those two. Coming back to your first question, indeed, it's true. There is no survival benefit for patients treated with EGFR TKIs and EGFR mutated tumors. But the way we approach this, I think, is something probably very stupid. We know for a long time that single agent therapy will never cure a patient with cancer. Now, what we did in 8 consecutive trials, take single agent therapies to patients with cancer, I think that was, in hindsight, not the best thing to do.
So perhaps if you combine it with c-Met inhibitor from the
Well,
beginning,
there
you may
are,
have a very
there
much
are a
better
number of
effect.
combinations possible, that's true, yes.
Any further questions?
Yes, may I also ask you a question? So would it be an approach in the clinic to do an EGFR scan initially to discriminate between EGFR TKI patients that do have uptake of EGFR inhibitors versus non-uptake, and then go further to design your treatment, because maybe you don't need your genetic analysis if you start first with an image?
Well, if you identify patients who have uptake of this tracer in the tumors, I think it's a reasonable approach to treat these patients with EGFR TKIs. So in that sense, it's okay. I'm a bit reluctant. First, we have to establish that patients actually do have lung cancer. So we will have a tissue or a cytological diagnosis already. Second, we can often do a mutation analysis or additional analyses on these patients to see whether they have a EGFR mutation. So I think for the diagnostic part, it's not really necessary. I think the most exciting part is if you find these rare mutations where you really do not know what to do, and you can really decide upon the picture or these treatments at relapse.